This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Welcome to another edition of Journal Club. As usual, we have two presenters this morning, two articles we're going to discuss. First up is Dr. Annie Ho. Annie is a second-year fellow in the clinical track, native Floridian, did a residency here at Emory, and she's going to present data, 5-year follow-up data from the COAP trial. So Annie, take it away.
Okay. Good morning, everyone. Happy Friday. Okay, so I'm going to talk about as Robbie said, the 5-year follow-up for the COAP trial, and I'll go into details about the trial too. I have no disclosures. So we'll discuss about the transcatheter edge-to-edge repair, aka the mitral clip by Abbott, and then review the COAP trial, and then review the 5-year follow-up data. So just to review, the clinical question that the COAP trial had was in patients with either moderate to severe or severe MR due to annular dilation, with heart failure, with reduced ejection fraction, who's on already good doses of GDMT, who are high surgical risk, does putting in a percutaneous mitral valve repair with mitral clip reduce the heart failure, hospitalization, or mortality? So that was the original question. And it was done in 2018. It was a multi-center randomized controlled trial, open label, and then patients were categorized or randomized into either GDMT plus mitral clip or just GDMT alone. And then I'll go into details about the inclusion and exclusion criteria of it. But let's look forward to what the 5-year follow-ups show, which basically shows that what we saw from the original data at the 2-year follow-up is still true at the 5-year follow-up. So that's a spoiler alert. And then I have the QR code for both articles up, the left from the 2018 data, and then the 5-year follow-up data that was presented at ACC this year. So I'll leave this on for a second so we could take, you guys could take pictures of it and get the article. Okay. So a little bit of background. So ischemic and non-ischemic cardiomyopathy of the left ventricle chamber results in chamber dilation, which then can dislocate the papillary muscles. So in patients with like chronic heart failure with reduced EF, this dilation results in secondary functional MR. So when the LV chamber dilates, and then there's another form of functional MR, which atrial functional MR, which is more like on the HFpEF atrial fib side. And then, so what this trial did was, studied the use of the mitral clip, which is a percutaneous device that approximates the anterior and posterior leaflets of the mitral valve, and then tried to reduce the severity of the MR. And then in this particular study, they used patients with moderately to severe or severe MR, and just I'm sure you guys know this already on how to assess MR. Interestingly, in this study, the average estimated like regurgitant orifice area was about 0.4 between both groups in the control and device group. So this study was done between December of 2012 and June of 2017, and it randomized about 600 patients to either half of them received the mitral clip with guideline-directed medical therapy, and then the controlled half of them just received the guideline-directed medical therapy. The mean age was about 72, and about half of them were female. So also the mean STS surgical risk score was about 8%. And then about over half of them had at least NYH class 3 or 4 symptoms. To be qualified for this trial, you had to already been on your max dose tolerated GDMT, and then have at least NYHA class 2 and above, and then have to have at least 3 or 4 plus MR. What they did is they did clinical and, they did follow-up clinically and with echo, which was performed at 30 days, at 6 months, 1 year, 18 months, 2 years, which is what the 2018 data published, up to 2 years, and then 3 and 5 years. Of note, in this study, after the 2-year visit, crossover treatment with the mitral clip was permitted in the control group, who still met all the original enrollment criteria. Okay, so basically kind of just talked about what I just said. So you have to have symptomatic, so NYH class 2 and above, MR, and due to ischemic or non-ischemic cardiomyopathy, the EF had to be between 20 and 50%, and your LV and diastolic diameter has to be less than 7 centimeters. And of course, things like they have to be, mitral clip has to be deemed feasible, and that they could go through a transeptal catheterization, and then also have femoral artery access to. So the principal exclusion includes, if your LV diameter is greater than 7, if you had severe pulmonary hypertension or symptomatic moderate to severe RV failure. And then there was also a centralized eligibility committee to confirm if all the criteria was met too. So the demographics around 72, 73 is the average age. 60% male, they had other comorbidities as well. So like the average BMI was around 27, 80% of them had hypertension, and all the comorbidities we typically see with our patients. So hyperlipidemia, history of CAD, half of them had an MI in the past, half of them had at least a PCI, and about 40% of them had CABG in the past, half of them had atrial fibrillation. And then in this study, about 60% of the patients had ischemic cardiomyopathy and 40% non-ischemic. And I would say like 50%, most of them had around NYH class 3 symptoms. And then, before they enrolled in this study, they're already on, the max dose guideline directed medical therapy, and already had PCIs and CRTD by societal guidelines. And then in terms of mitral regurg, about 55% of them had moderate to severe MR, and then 45% had severe MR. Okay, so from the 2018 trial, they looked at primary outcomes and secondary outcome. Primary outcome being hospitalization for heart failure. And then for the secondary outcome, all-cause mortality, they did it at 12 months, 24 months in the original study, and then, of course, at 5-year mark too. But as you could see that the mitral clip group did better in terms of hospitalization, 35% at 2 years, and then compared to 67, almost 68% for the control group at 2 years. And then in looking at all-cause mortality at even a year into it, 20% of the patients who received a mitral clip with GDMT died, and then about 23%, a little bit higher for the only GDMT group. And then you could see that there's a bigger difference, like more remarkable at the 2-year mark. So close to 30% of the patients who received mitral clip and GDMT died, and then 46% of the patients who only received GDMT died. So because of this data, it was so strongly positive from the outcome of the study. Some of the guidelines actually changed to incorporate adding mitral clip into their guidelines. So for example, the most recent European Society of Cardiology guidelines do recommend this. So if you had secondary MR patients who met the COAP trial inclusion criteria, it is a 2A recommendation for the mitral clip, and then 2B recommendation to consider the mitral clip after careful evaluation of other treatments if they didn't meet the criteria that was in the study, which I highlighted in red. Okay, and then here you see kind of just a schematic of the study, and then at the 5-year follow-up, you could still see that the patients who received the mitral clip and was on GDMT had lower mortality and also heart failure hospitalizations, even at the 5-year mark. And we'll kind of go into a deeper dive of that too. Let's see. One thing with both groups, as we saw at the 2-year mark, is pretty significant, the differences, but death or hospitalization combined reach about 91, almost 92% in the control group versus 73% in the mitral group, which is a big number. So, you know, like 90% of your patients dying. It's just these patients are so sick, you know, they have heart failure and they have also severe, at least moderate to severe MR. So that's a little something to consider too. Okay, so at the 5-year follow-up, the all-cause mortality through 5 years was 57% in the device group versus 67% in the control group. And then death or hospitalization for heart failure within 5 years occurred in 70% in the patients with the device group and 91% in the control group that we talked about. And then they also looked at like device specific safety events that occurred within the 5 years and only occurred in 1.4% of the device group. So device specific safety events, including complications from inserting the device. So device embolization or causing endocarditis or surgical complications. And of that 1.4%, those complications occurred within 30 days after the procedure. Okay, so this is from data from the 5-year follow-up. These are Kaplan-Meier time to event curves for hospitalization for heart failure and death from any cause. And the mitral clip group was associated with lower rates of hospitalization and hospitalizations from cardiovascular causes and heart failure during the 5-year follow-up compared to the control group. And then we'll look into a post hoc analysis of it and see the difference after 3 years, because there is a change after 3 years. So overall, based on the data, mitral clip led to a lower rate of hospitalization for heart failure and then also all-cause mortality. And even despite the protocol permitting the crossover treatment for those who did after 2 years who got mitral clip for their severe MR. So this is the post hoc analysis in the differences in hospitalization for heart failure and mortality. You could see that it diverged after about 3 years, there's a greater difference in the first 3 years, and then kind of diminishes after the 3rd year, the 3-year. The diminishing treatment effect during the late follow-up in this trial is probably large in part of the performance of the mitral clip. In the 45% of the patients in the control group surviving to 2 years, and then can do the crossover procedure that was allowed by the protocol. So big take home point among patients with heart failure with moderate to severe or severe secondary MR who remain symptomatic despite being on max dose guideline directed medical therapy. The mitral clip or transcatheter edge-to-edge repair of the mitral valve was safe and did lead to a lower rate of hospitalization for heart failure and also all-cause mortality through the 5-year follow-up, just compared to medical therapy alone. The treatment of secondary mitral regurg in a high risk heart failure population with the mitral clip did lead to persistent reduction in both deaths and heart failure, and then improved quality of life. And it was deemed that this therapy was pretty safe, since the risk was with 1%, and that happened within the first 30 days of implantation. Every study has limitations. The limitation with this one, with the standard of care for patients with heart failure evolved during the COAPT trial, which started enrolling in 2012. And the data came out in 2018. So the use of ARNIs and SGLT2 inhibitors wasn't as robust as it is now. During the study enrollment, there was only 3 patients that were on SGLT2 inhibitors. So, we could consider, or should definitely consider, a redo of the COAPT trial in all patients when they're first optimized on the 4 pillars of the heart failure therapy, and then, CRTD as needed. And then the other thing is, there was another study, the Mitral FR trial, that studied the mitral clip as well, but fail to show the same type of data. So, because there's 2 studies on the mitral clip and the results are, contrasting, it kind of questions the reproducibility of the study. So we need to get to do, further investigation with one, either making sure that patients have all 4 pillars, and then also seeing if this data is true after that. Oh, that's my baby. Questions, thoughts?
Adorable baby.
Thank you.
Have they, I don't think this has happened with this. Maybe I remember seeing this with COAPT. Have they done did they ever do subgroup analyses looking at because with mitral clip, you can have sort of variable effectiveness in terms of reducing mitral regurgitation. Have they looked at that and seen, that there is a correlation between how good a job you do reducing mitral regurgitation, or no, or does it seem to be somewhat independent and it's just sort of maybe more of a ventricular remodeling thing by the actual, as opposed to the mitral regurgitation effectiveness repair? So
yeah, I don't think they did look into the effectiveness of it, but when they did the study at the time of discharge, the group that got the mitral clip did have a significant reduction in their MR. So to at least mild, 80%, 82% of patients had their moderate to severe or severe MR reduced to mild.
Other questions, thoughts from the group?
Stan Sharpen. Go ahead, Patrick. You go.
Yeah, I was just going to comment on that, Robbie. So 2 things. Number one, the main differences between the Mitra FR and the COAPT trial were essentially the Mitra FR trial. When they enrolled patients, they started them on guideline-directed medical therapy at that time, whereas to get into COAPT, you had to already be on maximally tolerated guideline-directed medical therapy. And so there were a lot of patients that were screened that ended up not being eligible for COAPT because their MR improved or their heart failure improved or something like that. So Mitra FR unfortunately tested 2 things at once, and not just the effectiveness of the clip, which is one reason why it was a negative trial. And then to answer your question about the reduction in the MR, they did look at that, and that was actually one of the differences between the Mitra FR and the COAPT group, in that the COAPT had a higher procedural success, meaning that they had more patients with a 2-grade reduction in their MR compared to the Mitra FR group. So those that will. So when we kind of grade the MR 1+, 2+, 3+, 4+, if you get a 2-grade reduction, those were the patients that saw the greatest benefit from clip.
Patrick, they seem to have I don't know, you obviously have more experience with this than most. What they seem to have, I think it was a 98% procedural success rate, and they seem to have a very robust reduction in mitral regurgitation. Do you feel like what they achieved in COAPT is at all reproducible in the real world?
It was a very highly selected patient population, so I think that what we see a lot of times are patients that get referred very late when their ventricles are blown out, and they've really had no other options, and people are just trying to do it. It's kind of as a compassionate use. And so in compassionate use cases in patients that, dialysis patients, patients with pulmonary hypertension and these types of things, I don't think you're going to see the same. I think in patients that are selected early and on good medical therapy, we get pretty good results, in those patients. So I think it's all about patient selection.
For example,
but yes,
I was going to say, they didn't have anyone with EFs less than 20 in their trial, for example.
Correct. Yeah. No, I mean.
Hey, it's Peter Block. Can I make a quick comment?
Of course.
Hello?
Yes, sir.
Can I make a quick comment? You mentioned somewhere along the way the whole business of ventricular remodeling. But remember, this device is not a ventricular remodeling device. And one of the problems, I think, with mitral clipping is that in the long run, whatever you want to call that, 3, 4, 5 years, 6 years, it's the ventricle that's going to get to these folks that have this severe MR to start with, functional mitral regurgitation. There are, as you know, new devices which are coming along, which actually may impact the ventricle, transcatheter ring placements, other posterior buttressing devices and so forth, which may in fact, in combination with the mitral clip, be a much better way of dealing with functional mitral regurgitation than we currently have. I mean, the mitral clip is a good device, but it probably is not a great device.
Thank you, sir.
Stan Sherman, did they look at mortality and exactly what Peter said? Did they divide the mortality in terms of those who did get some improvement in EF versus those who did not?
I don't think they did. They didn't look into the improvement of EF. They looked into hospitalization from heart failure, all-cause mortality, improvement in MR were the big things.
Gotcha.
I think that tells you that the EFs did not change very much.
Okay. Well, any final questions, comments from the group? Well, good. An interesting trial. I mean, look, and certainly a positive trial that seems like in the right group, this is a very viable sort of a piece to add, along with GDMT and possible cardiac resynchronization, but another thing to consider in your patients with moderate to severe MR, or moderate to severe MR. So, all right. Thanks, Annie. Appreciate it.
Thanks, everyone.
Our next presenter is Godley Jack. Godley is a third-year fellow in the clinical track, native of Maryland. Did his residency at the University of North Carolina, and going to talk to us, as you can see on his slides, transcatheter arterialization of deep veins and chronic limb-threatening ischemia. All right, take it away, Godley.
Good morning, everyone. So my topic, the title of this paper, it was just published in the New England Journal 1 or 2 weeks ago. The title is Transcatheter Arterialization of the Deep Veins and Chronic Limb-Threatening Ischemia. And I chose this article specifically because I'm on my vascular rotation this month, and I wanted to pick an article that related to it. And as always, I like to pick an article about something I know nothing about, and this was consistent. So let's move on to our objective. So First, I'd like to define very briefly the arterial and venous anatomy and give us a refresher of the anatomy of the lower extremity. We're going to define and describe arterialization of the veins as a technique itself. I think we can't go without briefly talking about the Partner 1 trial, but then I'm going to spend the bulk of this talk talking about the findings of the Partner 2 trial. I think I'd be remiss without very briefly going over the anatomy of the lower extremity. So off the aorta, we have our common iliac artery that splits into our internal, external iliac arteries. The common femoral artery extends from the external iliac. It splits into the SFA and the profunda. The SFA, when it goes behind the knee, distal to becomes the popliteal. And then just distal to that has a trifurcation of the anterior and posterior tibial arteries and the perineals. We really have to make sure we have a good understanding of the definitions of the diagnoses that we're talking about. So the focus of this talk is chronic limb-threatening ischemia. I think it was formerly known as critical limb ischemia. Chronic, let's just say chronic limb ischemia. But chronic limb-threatening ischemia as a clinical syndrome defined by the presence of PAD, specifically with combination of rest pain, gangrene, or lower limb ulceration. And the key distinguishing feature is it's greater than 2 weeks. And the presence of rest pain is really probably the most critical and important thing to define and to be aware of. Acute limb ischemia is usually going to be, again, it's similar, but less than 2 weeks. So I think one of the things that I found interesting about this article, again, I had never heard of arterialization of a vein, but this treatment is important because it's, I'll get into it, but arterial revascularization is going to be standard of care in patients with chronic limb ischemia. But the problem is, despite our advances in both endovascular treatment and surgical correction, up to 20% of these patients are not candidates for either because they don't have good distal targets, or we're not able to harvest a vessel that we can use. And those patients that are not candidates for either surgical or endovascular treatment are referred to as no option patients for the rest of this talk and for the rest of the study. And without restoration of blood flow, these patients have high mortality, high morbidity, poor quality of life, and they generally don't do well. Clinically, that's going to manifest as limb pain, non-healing wounds, gangrene, and oftentimes are going to lead to amputation. So transcatheter arterialization of the deep veins, it's an endovascular revascularization. It's an endovascular technique for the treatment of this subset of patients with severe PAD. So let's start by just defining what is arterialization of a vein. To put it simply, it's exactly what it sounds like. It's taking a vein and using either surgical or interventional techniques to turn that vein into an artery. The technique or the thought process is not new. Actually, about 100 years ago, surgical attempts were begun. The problem with these techniques is that they were kind of wrought with complications, including infection. The incision to get down to the arteries was very deep. There was difficulty lysing the venous valves. And there was a steel phenomenon with which the tributaries of the vein got blood flow rather than the blood flow going to the distal organs. So there was a steel phenomenon from that. I put together this very basic diagram of what arterialization, of the concept of it. And then after this, we're going to go into the details of what's called the limb flow system. But so if we start with our diagram with normal physiology, we have arterial flow bringing oxygen, nutrients, and glucose to our end organs. And then they go back up the veins across one-way valves. In peripheral artery disease or chronic limb-threatening ischemia, we have plaque buildup across our arteries that deny oxygen-rich blood to the end organs. So in a nutshell, what we do in arterialization of a vein, So the first thing we do is we got to get rid of the one-way valves. And after we get rid of the one-way valves, we create a crossing point, or essentially an AV fistula between the artery and the vein, just proximal to the point of obstruction. And what we're going to do after we create that AV fistula is produce a conduit that brings blood, oxygenated blood, over from the artery across into the vein, and we're just going to stent all the way down. We're going to stent all the way on down, and to allow oxygenated blood to reach the end organs, essentially using the vein kind of as a scaffold, or as a a structural basis for our stent. Now, when I heard about this, my first question was, if the artery is blocked and the vein is being used as the conduit for forward or anterograde flow, where does the blood go after that? So essentially, so the oxygenated blood moves retrograde through the capillary beds, retrograde through the vein, and retrograde through the capillary beds to feed the end organs. But where does it go after that? Again, if the artery is blocked and the vein is already being used, that was my first question. But the answer is simple. You have other veins outside of the one that you intervened on that can carry that blood away from the capillary beds. And I included this venous anatomy because it's important to know. But the most common, in this study, the most common vein that they utilized for that conduit, we'll call it a conduit, was the posterior tibial vein. But it's important to know our anatomy because we still have a fibular vein. As far as the deep veins, you still have a fibular vein and an anterior tibial vein to return deoxygenated blood back up the leg. So that's the concept. So this is what an angiogram of that would look like. Well, I have more examples of these, but your conduit is it's kind of hard to see. It's going to be this, or it might be this one, and then you have blood returning back up. So I'll have more pictures of this later on. So now that we have a good understanding of the basics of what arterialization is, we can talk about the limb flow system. So limb flow actually funded the study. Step one, we're going to use ultrasound guidance to advance to get a wire into the proximal posterior tibial vein. We're going to advance that wire all the way up the leg into the posterior tibial vein, the proximal posterior tibial vein, to the level of the crossing point, which I'll talk about in a second. So we get your wire up and you get your catheter up here, again, from the distal foot all the way up to your crossing target. And then we essentially have, from the other end, you're going to get femoral access, and anterograde, you're going to advance a wire and another catheter. This is going to be a 7 French catheter in the arterial and a 4 French in the venous. So the ipsilateral femoral artery is accessed through an anterograde technique. The arterial and venous catheters are introduced from opposite ends, and they meet at the crossing point here. 99% of the time, the tibial vein was used, and the tibial artery was used about 75% of the time. We'll go into that later. So this is a picture from the limb flow of the limb flow system. So once we have our arterial catheter and venous catheter juxtaposed, once the distal ends of the catheters are juxtaposed from opposite ends, coming out of the arterial, the distal arterial catheter is a small needle, and that's able to cross the artery, puncture the artery and the vein, and then out of that needle we advance a small wire. The small wire enters a mesh that we have to expand. So the distal tip of the vein, we expand that mesh. The mesh captures, we clamp the mesh closed and capture the wire from the arterial side, and then we can essentially remove both, and then we have a wire going all the way from the right groin arterial, and we can pull that wire all the way out of the foot. So I thought that was interesting. So you have through and through access from the groin in the right all the way out to a person's plantar surface of their foot. So that's interesting. So once you have that wire in, the arterial catheter comes out, you leave the venous access, the venous sheath in. And this is just a fluoro image of that snare. These are just pictures from the paper of the arterial catheter needle and the venous catheter as well. Next, now that we have that access, we're going to dilate our crossing point, or crossover point, excuse me. Next step, we got to get rid of the one-way valves. So remember, we need anterograde, or I guess retrograde flow down this vein towards the foot, and the valves get in the way of that. So we have what's called a valvular tone, which is going to essentially eradicate the functionality of these valves as we pass it through the vein itself. And after successful valvulotomy, we do balloon dilatation of the tibial vein to make enough space for our graft to go in. This is what it's going to look like towards the end. And I want you guys to take a close look at this. I think this is interesting. So here we see that. So first take a look, and you see that all of the arterial access to the foot is almost completely occluded. So your ATA, PTA, perineal, all occluded. And then we have this, after we stent all the way up, essentially we have this flow down the artery, we cross over just proximal to our occlusive point. Oxygenated blood goes through the vein, retrograde through the capillaries, fills the capillary system, and then moves, I guess you call it anterograde, up the other veins in the leg to give perfusion. So we have self-expanding stents that are deployed. You have one self-expanding stent deployed from just distal to the crossing point to the end of the foot. And then you have a tapered stent that crosses over, that you layer over that. And this is what you get at the end. And this is what you get at the end. So here we have our stent going down here. It's providing flow. And you can see that we now have achieved flow throughout the foot, and the venous return going up here. These are more pictures. So now that we have a very quick basic understanding of how this is done and what this means, let's talk about the progression of this technique itself and whether it works. So this was started out, there were cases of these were first done, I think, in Singapore and one country in North America, I can't remember, but Singapore was actually where this started. And then after that was successful, we started off with the PROMISE 1 trial. And the PROMISE 1 trial was a small trial to establish the feasibility of this technique, this transcatheter technique, and answer the question, is this possible? Does this work? So they took 32 patients with no option chronic limb-threatening ischemia that were previously offered major amputation. And I believe these were patients that declined amputation, if I remember correctly. This was a single arm study, again, just to check the feasibility. And one major thing to know is they took, I would say, relatively healthy patients for this study. So I'm pretty sure they excluded patients with heart failure and end-stage renal disease in these patients, in this group. They were assessed for clinical status, pain, wound healing at several intervals, 38, 6 months, and 12 months. And the primary endpoint was amputation-free survival at 30 days and 6 and 12 months. This was overall a successful study. 97% of cases were successful. Only one case was not. And the amputation-free survival, that's being alive and not having an amputation, at 30 days, 6 months, and 12 months was 91%, 74%, and 70% respectively. But of course, this was a small study. There was a high rate of reintervention. About 88% of people needed some type of procedure thereafter. Here you can see a graph of wound status over time. Clearly this improves with patients with healed or healing or fully healed, just going up over time. Average wound area over time went down in this small study. And then they used the wound ischemia and foot infection classification system designed by the Society for Vascular Surgery to assess these patients as well. And essentially they used subjective and objective criteria to assess to categorize the severity of the wound, the ischemia, and the infection. And all three of those improved over time in this patient population. So the summary of Promise 1 was that the limb flow system worked. It was feasible, it was safe and effective in that population, but obviously more studies and larger studies were needed. Promise 2. So what was the purpose? So Promise 2 said, okay, we know that the system works, but now let's take it to a more realistic patient population. Let's look at a bigger patient population. And the big difference is they actually set an arbitrary success rate and said, let's compare the data to that arbitrary success rate or a percentage of success that we will call good. I think it was like 55 or 56% success rate. And they compared it to that success rate. So the purpose, again, was to expand on Promise 1. The design is also a single group study, multi-center, to evaluate safety and efficacy of the transcatheter arterialization of deep veins. And again, we're only taking patients with no option status. And it was funded by the sponsor. The sponsor was LimFlow, the creator of the technology. Population, chronic limb-threatening ischemia with no option, like we said, and Rutherford class 5 or 6. The primary endpoint was important to note. So again, amputation-free survival, so being alive and not having a limb removed at 6 months specifically. So we're just looking at 6 months as that cutoff. So 54% was that. I'm not sure where this came from. It's not in the article itself, but they chose an arbitrary number of 54. And they said if 54% or more people live to meet the primary endpoint, then this was successful. Characteristics at baseline. So the median age was 70, 72% were male. And I thought that the study made a specific effort point to note out that I think 44 or 46% of patients were either Black or African American, Hispanic or Latino. 81% had diabetes. 19 patients or 18% were on dialysis, and 74% of these people had a prior intervention. I included this just to remind myself to mention the Rutherford classification. 5 or 6 is essentially, so this is a classification of the severity of PAD. And 5 and 6 is essentially when you start to see tissue loss. So 5 being non-healing ulcers, focal gangrene with diffuse pedal edema, and 6 being essentially major tissue loss and more extensive tissue loss where the function of the foot is no longer salvageable. Procedural characteristics. Only one patient was not successful. So 104 out of 105 were. Where did the crossing point occur? So when it comes to the vein, 94% of people had that crossing point at the tibial vein, and the perineal vein was used in 6%. The next part doesn't make as much sense to me, but what artery did they use to cross over? You would think that the tibial artery rate would match the tibial vein rate. It doesn't. Why it doesn't, I don't understand, but it's 79%. The perineal artery was 20%, and the tibial perineal trunk was 6%. So I guess what that means is they were able to cross from the perineal artery to the tibial vein in a certain percentage of cases. And we have a 36% reintervention rate. Here are the major results. So we want to take some time for this. So first, like I said, 104 out of 105 patients had a successful procedure. That was 99%. I think that reaffirmed that the limb flow system, in the short term, it works. The procedure is successful, and there were no major complications. The amputation-free survival was 66.1%, and again, that was being alive at 6 months and not having an amputation by 6 months. They saw improved wound healing with complete healing in 16 patients, at 25%, partial wound healing in 32 patients, that was half, at the 6-month mark. And among patients with dialysis, this is important. So patients who were end-stage renal disease saw worse outcomes, essentially. So amputation-free survival was lower, and they had a higher mortality if they were end-stage renal, and I have a separate slide on that. A few minutes left. So this is just a plot of Bayesian credible interval, and kind of just shows graphically the vertical line being our cutoff point that was arbitrarily decided at 54%. And then here we have our patient group that's well over that. And on the right, we have amputation-free survival, Kaplan-Meier curve over 1 year. I wanted to put a separate slide in for patients with end-stage renal disease because, they're such a significant portion of our patient population with peripheral artery disease. And long story short, they did not do well. So 19 patients that were dialysis dependent, they had amputation-free survival of only 37%, whereas the rest of the patient population had amputation-free survival of 72%. And you could see that one of two ways. So one, end-stage renal patients didn't do well, but if you have a patient without end-stage renal disease, they do even better with this technique and in this study. So really the overall, the outcomes of the study were driven down by the end-stage renal group, which is not much of a surprise. This is a picture rendition of one patient over time after the study. And my major takeaway is, so PROMISE 1 established that the limb flow system was technically adequate. And the PROMISE 2 took this a step further, took a larger patient sample, and then used an arbitrary cutoff, specifically because it's hard to come up with a control group for this. And I'll get into that in my next slide. Limitations, it was funded by LimFlow. There was no control group. Obviously, so a control group kind of provides an ethical dilemma because the only way to do this the right way would be to have one group be the limb flow intervention group and one group be an amputation group. But it's hard to, it's kind of hard to do a study like that. And that's a whole nother discussion, but repeat interventions were also high in this study, the second study, PROMISE 2 with 36%, and there was only 12-month follow-up. Next questions would be, does arterialization of the veins have comparable survival to amputation? So if we, I kind of touched on this, but if we choose to arterialize someone's vein rather than jumping straight to amputation, do these patients in that arm, do they live as long? What's the quality of life? Things like that, hospitalizations. That's it. Thank you very much. I'll take any questions.
Thanks, Godley. And I apologize if you said this. I had to take a quick phone call while you were talking, so apologies if you covered this. But these were patients that were, I guess, either because of with their critical limb ischemia, not deemed surgical candidates, either because of their risk or their anatomy.
Right. So they were, it's anatomy. So they were tagged as no option for surgical revascularization. Or interventional revascularization. They no option for surgical revascularization because they had no distal targets, number one, or they did not have a harvestable vessel to bypass with. Those were the two reasons. Right, and they hadn't.
These were amputation or this essentially. It was
no. So there was no.
No. Right. If they didn't have this procedure to offer,
right.
it was
right. Right. And I think in PROMISE 1, if I recall correctly, those patients refused to be amputated. Yeah. So that's why they had a patient population to work with. And for PROMISE 2, I know they had an independent kind of a group of physicians who made sure that these people were truly no option before they were enrolled in the study.
Well, yeah, I guess my comments were, I think it's a good sort of proof of concept of this additional therapeutic option and folks that have limited options. It seems like the procedural success rate was pretty high for something that, at least from a non-interventionalist, clearly seems like it would be not the easiest procedure just technically to perform, and they had 98% or something like this, 90% success rate. So, and then so another interesting, like you said, it would be hard to do a controlled trial, but at least this is a proof of concept that there is this other option that in some cases may prevent, at least in the short term, amputation. So, any other comments, questions?
Hey, Godley. Hey, Godley.
Yes, sir. Good morning.
Thank you for that great presentation. I can tell you want to try this. Number
Wait,
one.
what?
Number two, maybe Peter can comment on this, but this has been tried in the heart, either experimentally, I think, by using the coronary sinus. Is that, you recall that? Did you encounter that? Or Peter, did you know anything about that?
Me? Oh, I have not heard. No, I had barely heard about this. I have not heard about it done in the
I'm pretty
coronaries.
sure somebody tried this with the coronary sinus, maybe experimentally or something.
Oh, wow. No, I hadn't heard about that.
Yeah, can I just make a comment about that, Steve? This is a deja vu all over again in terms of the heart, because I'm trying to think of when, I think early 2000s, the concept was to take particularly the circumflex artery, if it was occluded, and bypass it not into the coronary sinus directly, but into one of the myocardial veins that runs along the circle on the lateral border of the heart, and do exactly the same thing, except that was a entry into the vein and then a re-entry back into the arteries distally, which was an interesting, making that short section of vein a bridge. It failed because of thrombosis and just very difficult technical problems, you might imagine, in a beating heart to make this work. I think in the periphery, I'm astonished that they did as well as they did, just in terms of reducing amputation. But my guess is that it's the size of vessels that make the difference. Technically, it's not that difficult. Remember, we now can put in transcatheter aortic valves from the femoral vein by crossing over into the aorta in the mid-abdomen, and not having any stent there, just using the catheters to go from the distal aorta into the, from the distal IVC into the aorta, and then passing the catheter through that up into the aortic valve area and placing the valve. So it isn't a difficult technical issue to do these things, but it's never easy either. But I think this is promising, and I think it's something to keep an eye on.
Godley, this was Khosrow, a great presentation. Just a couple of comments. About 20 years back, initially this procedure was developed for the SFA occlusion, where you would enter proximally into the femoral vein that travel adjacent to it, and then re-enter either the popliteal or the distal femoral artery, just like Peter was mentioning over here in the coronaries. But that procedure never, doing the procedure is technically not difficult, as Peter said, but that procedure never took off because our devices have improved in crossing these CTOs. We still have a small percentage. They set up to 20%, but I think it all depends on the technical expertise of the operators. When we can't get through a CTO, and that problem is usually encountered, that I have encountered, is when they are heavily calcified. And heavy calcification I usually see in patients on dialysis or longstanding diabetes mellitus. So in those patients, I think this option. Now remember, this option is only they're talking about below the knee vessels. They are not talking of the SFA, because SFA was tried 20 years back. And below the knee vessel, in your anatomy, when you were explaining, all the arteries have duplicate veins. So there are two posterior tibial veins that are traveling. In fact, when you do ultrasound of the radial artery, when we do access, I try to show the fellows that there are veins lying adjacent and the arteries in the center. When you compress with the probe, the veins get compressed. So the same thing with the posterior tibial vein. they are duplicate veins in the legs, so you can use one vein. But the problem with this procedure is you need revascularization, and it was pretty high rate that they had to go in for secondary revascularization because the stents would start occluding. And that is one of the issues. And there will be a control arm because our Professor Kajuni is doing research where, I don't know if he's online or not, where he's injecting growth factors and trying to see if collateral microscopic blood vessels can be developed that can provide blood flow. So I think somewhere down the road, this trial will have to be randomized into 3 arms, one with this procedure, one with amputation, and one with these new novel medications that will be developed. Thank you.
Thank you, Dr. Niazi.
I have
go ahead,
Stan Sherman. I think that between Promise 1 and Promise 2, it looks like the need to go back in again was markedly decreased. I guess the people doing the work, got better at this. But what were the procedures that were done that needed to be done again 36% of the time? What did they do these second procedures?
It was in the supplemental paper, but I didn't have access to it. But I can try to find it and get back to you.
Stan, it was basically going back in and again doing balloon angioplasty because they will start developing restenosis with impaired flow down into the vein. Remember, these self-expanding stents are covered stents, and so even by putting them in the vein doesn't mean that they will not develop plaque formation. So the secondary, and in peripheral, they call them secondary patency, which basically is restenosis that has developed and you're going in with and recanalizing it.
Gotcha.
Godly, this is Manj. Okay, this is a really good talk. Very interesting, very clever idea. I am curious, and I think Khusro probably touched onto this, why we don't see steel. Why we don't see, if you cause an AV fistula, you should theoretically reduce perfusion to the limb. But here we are increasing perfusion to the limb. And I assume it's because there's redundancy in the venous system and because the underlying tissue perfusion is so poor with underlying necrosis that that environment allows for you to reverse the flow. Because I'll tell you, in many other circumstances, when you try to reverse flow in a vessel, whether a vein or an artery, it end up causing problems. A perfect example is when you have Al Kappa and you try to, and after the repair, sometimes you have watershed infarct when you reverse the flow down the left coronary. But I wonder if there's any more insight from you, Godly, or from anyone else as to why this works. And I guess it can only work maybe in the lower limbs and probably not in other places.
I can try very briefly to answer that, and I'll leave it to Niazi. But one, I think it works because in this case, all the major branches of the artery, all the arteries were completely occluded in these patients. So it's almost a complete vacuum of blood flow in the leg. So providing blood flow down that venous conduit works in that sense. And the second thing, so there was a steel phenomenon in the surgical groups early on, but that usually had to do with venous tributaries. So you would have blood flow going down the venous tributaries instead of going down to the target organs. But that problem is not really a problem when you have a sheath that covers or occludes those venous tributaries. I'm not sure if that answers your question.
Aman, what you are saying is you're very right. And the reason what happens is with the venous, and they didn't comment on this thing, when you take away a vein, a healthy vein in a lower extremity, like when the surgeons take away the superficial veins for bypass, you probably have seen in your patients a chronic low-grade swelling of that lower extremity. And that because they're taking a competent vein. So in this article, they didn't mention because they only followed them for 6 months right now. But when we treat chronic venous insufficiency, where we are occluding a diseased vein, a superficial vein, we are ablating one, the swelling goes down because over there, there's too much blood coming backwards. Whereas when you take a healthy vein for bypass surgery, you're taking a competent vein, which was draining a segment of the tissue. And that's why they develop a little bit of chronic swelling of that lower extremity from where the vein was harvested from by the surgeons.
Okay, well, thank you, everybody. Excellent discussion. Thank you, Godley, and thank you, Annie, for those presentations. Hope everybody has a fantastic Friday, and we'll see you next week.
The preceding program is copyrighted by Emory University.